the first topic is we are going to do a review of the top things from last year's event, in case you missed it. So with that, we have the Pediatric Surgery Fellows at Akron Children's and Cincinnati Children's, Dr. Alex Gibbons, Dr. Ray Hanke, and Dr. Alexandra Casar. And they are going to go through quickly what you missed last year. So Alex?
So the practice gaps identified by the Pediatric Surgery Practice Professional Development Committee last year were very popular. They're also very popular on social media, and you've seen our videos. Number 10 for last year was restrictive transfusion protocols, using a target hemoglobin of 7 for transfusions instead of 8 or 9 or 10, like some institutional protocols did, and it showed that there's no difference in mortality. They also recommended to be aware of the risk of DVT using blood transfusions. Just
so you know, just 2 days ago, I had a baby that I was operating on, and because you taught me this, the hemoglobin, they were going to transfuse up to a hematocrit of 30. I said, no, I learned from the PDC, we don't have to do that anymore.
Transfuse clinically.
Transfuse clinically. Okay.
So we want to ask a question. Has your practice changed since last year when we presented this? So the poll should be loading, and you can start participating.
Who here? See, you guys don't count because you're skewed. You guys are ahead of everybody else because you're the PDC. But has anyone here still transfused to a hematocrit of 30 or a hemoglobin of 10? So I was the only one. So embarrassing every year. It's always
every year.
Yeah, every year.
Only the exception would be sickle cell disease.
Okay.
So sickle cell disease, there's some poor evidence to suggest that their hematocrit needs to be around 30, or you need to measure their sickle cell fraction and make sure that the HBSS is below, I think, 50 or 50%, to make sure that they can go through easily.
That's good. That's a great point.
60% of you were doing it already. That's awesome. 20% have converted, and 20 didn't know. So pay attention to the gaps this year so you'll know for next year. Here we go.
Yeah, that's why we're reviewing it this year. So number 9 was enteral nutrition in pancreatitis. So what the PDC emphasized is that early feeding decreases morbidity, infectious complications, and overall mortality. They found that nasogastric is equal to nasojejunal feeding. It's equally tolerated, which I found fascinating because it's always been NJ feeds for my training. And then operate early for gallstone pancreatitis. So, question for you all. Are you enterally feeding children with pancreatitis early on?
I remember in last year's update course, one of the highlight reels was Dr. Rusty Jennings saying that this single teaching point made the whole update course worth it because he didn't realize this and it totally changed his practice.
Yep.
He had a Todd Ponsky mind blown moment.
This is one of those things I was doing wrong again. I would wait until their symptoms were improving. I wasn't following lipase and amylase, but I was waiting for their symptoms to improve. And now you don't have to do that. You just feed right away if they can tolerate it.
So the 8th one, to paraphrase the rapper Childish Gambino, is like an accent mark. It was all about the ovaries. So this was referring to ovarian torsion specifically, and the points that the PDC wanted to emphasize were, 1, that ultrasound is not a great tool to be using for diagnosis at this stage, so really don't be basing your clinical judgment off of that. And then 2, when you go in to detorse, even if the ovary looks black and dead, you leave it in place because they can still have recovery afterwards, and it helps preserve fertility.
Number 7, we have VTE prophylaxis in high-risk trauma patients. And the learning gap was that for low bleeding risk, we should be doing SCDs and low molecular weight heparin. And for high bleeding risk, we should be doing SCDs until the patients are ambulatory, and then do a screening ultrasound on ICU day 7. The question was, are you using low molecular weight heparin and SCDs in low-risk trauma patients?
So, first of all, what age? Is this any age, or is this a certain age we should start using low molecular weight heparin? I don't know. Does anyone know? We'll have to look that up, because I don't know. Do you have to do this in a 5-year-old, or is this only a teenager? Who is it that you need to give low molecular weight heparin? Do you guys know? I don't know. No? What do you do? What do you do in your practice?
So our institution policy is 12 and over.
12 and over.
Yes,
okay.
sir.
And you do both SCDs and low molecular heparin if they don't have a head bleed.
Correct. Well, if they're high risk, they
high
get
risk.
both. If they're low risk, they get just SEDs.
And high risk would be solid organ injury, or is that not high risk?
Femur fractures, cervical
with-
spine fracture, intubated.
Anyone do anything different? No? Okay.
There was data presented at APSA this year by the group, I think the TOMAC group and their subsidiaries. They presented some data on that, trying to adopt VTE prophylaxis protocols. So they're doing more and more prophylaxis, and it's mostly the teenagers, as Liz mentioned, who have ambulation issues, and they are supposed to be at high risk.
Okay.
No one knows what that risk is, though.
Okay.
The other group that's at high risk are kids with IBD.
Really?
They're probably the most at-risk group for deep venous thromboses.
Okay. All right, what's next?
So number 6, the PDC called attention to the topic of physician wellness. They reviewed that burnout, it directly impacts patient care and outcomes, and emphasized the importance of establishing support systems that are established during education as well as practice. And this is something that needs to be proactive so that surgeons don't necessarily have to go out. When you're burnt out, you're not likely to seek out help. It's not necessarily in our mentality. It's not our norm. So that was another point that they emphasized.
So let me, while we put your poll up, and I
Okay.
want to ask, so have you talked to your hospital system about a proactive physician wellness program or participated in one yourself? So my answer to that is C. Well, it's not that I'm not convinced, I just haven't. Let me ask the leadership here, people that are in leadership positions, which are, I think are all of you. Have you done anything at your hospitals officially or formally for this? Mark Wolken says yes. Come up here. Well, we're waiting. Yeah.
No, that's okay. No, we have a very formal program. Most people know my partner, Kurt Heiss, who has set up a whole second victim program, but we're also, our wellness committee looks really extensively at burnout. We've polled the medical staff about burnout, and then we try to do things to help with that.
Dan?
I would say we also have a similar program, but I think it's also important to recognize that it's not just physicians who have this burnout issue in healthcare. And so we have representatives from patient services and from HR for the staff for issues of burnout. And, you know, we have a approach where we do acute interventions for things like we had a couple of kids pass away in the emergency department a while back, very close to each other, and so there were interventions made to help the staff down there deal with those sorts of issues. But it is a real issue.
That's a great
and
point. Yeah, that's actually a great point. And I'm curious for the international community, we'd love to hear if this is everywhere. Is this just a big United States thing right now, or is this happening all over the world? So please leave your comments and tell us if it's happening in your neck of the woods. All right, what's next?
So next one is also a more U.S. specific one. It was looking at firearm injury prevention and referring to gun violence as a public health issue and an epidemic, really. And APSA just in the most recent JPS issue for July had position statements that they had. One was for non-accidental trauma, and the other one was for firearm injuries. Fantastic position paper, so definitely recommend everybody take a look at that. But this practice gap was also addressing that and just emphasizing that physicians should be talking to their patients about whether there's a firearm in the home, and if there is, whether it's safely stored. And then the other aspect of it was kind of emphasizing advocacy and pushing for better policies that really help address the problem of gun violence.
All right, I need some help here. So I don't get where we fall into the politics arena. I have never talked to a patient about firearms, ever. And so I'm the one that needs to get into that mode. But I don't know how this works. How does APSA, how do pediatric surgeons, are we allowed to take a political stance on something?
So this erupted into a big political controversy in Florida recently. The American Academy of Pediatrics wanted to include this as a question that physicians should feel comfortable asking all parents. And as a matter of fact, they wanted to say that physicians should ask it and put it on their list of things they should ask. And it became a huge controversy. And the legislation, they basically, in Tallahassee, they shut that down. And they did not want that to go through as that. So I think as soon as you bring up a question like this and try to formalize it, you enter into the political arena with both feet. And so I think if you're going to do this, you have to be prepared to do that.
What are we supposed to do, Salim? It says, do you ask them, okay, do you have firearms in the house? Yes. Is it that we're supposed to tell them, do you have safety mechanisms?
Correct.
Okay.
So do you have firearms in the house? If the answer is yes, how do you store them? Are you keeping them under a lock and key? And are they loaded or are they kept unloaded? Is the ammunition kept separate from the guns or is it right next to them? And who has access to them? So that is what primary care physicians especially are supposed to do. And when, I've kind of done it a few times when there's been a trauma situation, it's kind of after the horse has already left the barn in a lot of ways. But yeah.
By the way, I had two friends, one this past week. I know someone who injured themselves by cleaning their gun. And apparently this happens a lot. It's cleaning the gun, there's a stray bullet, you either shoot yourself or someone else in the house. So that's something else to keep in mind. Interesting variation there in the answers. Next.
Practice gap number 4. This one was really interesting last year because everyone said they knew about it, and probably like 90% of people were still not doing it. So this is a transition from before, where isotonic fluids would be switched to hypotonic fluids for maintenance and resuscitation, to the current strategy that should be to continue isotonic fluids throughout. And this decreases the risk of hyponatremia. And it had similar morbid mortality otherwise.
Let's see what the poll says. So, comments on this. So, I was blown away by this. I have always okay, first day, resuscitate them, the next day put them on maintenance fluid at a hypotonic solution. I said, oh my God, okay, now I need to keep everybody on isotonic, and I can't do it. A lot of it's because of our EPIC.
Protocols?
What?
Order sets.
Order sets that I'd have to go change the whole EPIC order set. So even though I tried, we still end up switching over. It's been too hard of a mountain to push. What about everyone here? Do you switch?
At our institution, we switched the order sets.
You did switch them.
Yes. We just
Man, you guys do everything right.
changed.
They got to go.
It was at the push of the pediatricians. So all the order sets throughout the institution were changed.
Amazing.
At our institution, we had lots of education with the residents, particularly surgery residents, neurosurgery residents that take care of kids. The pediatricians were doing this, but we had to do that to make the change.
Steve, not babies, right? Or what about pylorics? Do you keep
I've switched for pylorics.
for them too?
Yes.
Because last year that was unclear when we talked about what about babies. It was a bit unclear at what age this starts. But you do it in everybody. Okay. Salim?
No, I agree. It's the biggest thing. It was almost like a culture change because when we were teaching medical students, we were teaching them that we're basing their fluid requirements on their sodium requirement on a daily basis, and so that's what we were traditionally teaching them in lectures and everything. So it was overcoming that. And once the pediatricians were convinced, then that helped us as well because the floors then wanted to do it. So we've switched over.
Okay. So once again, what is this? Question 9, I'm still the only one who's getting everyone wrong. Okay, let's keep going.
Well, it seems like 46% of people were already doing this. 38 have converted and 15 didn't know.
I'm just curious, at your hospitals, they won't hear or see you on camera, but did you guys all switch to this? This is Dr. Fred Rescorla, who we haven't introduced yet, from Indiana.
So we switched for many of our patients. We had a big discussion with our peds nephrology division, and they actually didn't want us to switch on everybody. We're starting a protocol of following lights on some of these kids, but they didn't think it was quite as big of a deal, and they thought this was kind of a quick jump on the pediatric group. So,
Interesting.
yeah.
So a little bit of a more tailored, measured approach.
Right.
Okay. All right.
Okay, so practice gap number 3, they identified violations of the Wilms tumor protocol. So a few things that we highlighted were remember to take the nodes every time, every operation, because if you don't, it automatically upstages your kids. remember that there's local and systemic staging, and that pulmonary metastasis doesn't preclude doing a primary nephrectomy. So I have two questions for the audience. So first, have you been sure to remove these nodes in your kids when you're operating for Wilms tumor?
Okay, so a comment about this. I think people know you're supposed to.
Yeah.
I'm guessing what happens is you're patting yourselves on the back that you took out the tumor, like, whew, okay, sweat, let's close. And I think it's a lapse because you were focused on the tumor. So it might be a good trick to tell the staff in the operating room, make sure you remind me to get nodes, put it on the whiteboard on the timeout. Make sure you have a hemostat to something and say, remind me to get the nodes. Maybe I think that might be part of it. Anyone comments?
So Liz, the question again here is, this is for sampling of nodes, and it's for primarily staging purposes, right?
Correct.
And so if you have a patient who does have known pulmonary mets, how important is it then to make sure that you take nodes in that situation, if your stage is already 4?
Well, I think I mean, that's an excellent question. What's the point? But on the other hand, to Todd's statement, if you get into the practice of doing it every time, then you're going to do it every time.
Do you want to?
There's also
Go ahead.
Go ahead, Dan.
It's important to still take the nodes because you treat the local disease and it has an impact on the treatment for the abdominal disease, whether they have lung mets or not. So it is important to take the nodes regardless.
This was a great discussion. Did you want to make another point, Liz?
I'm good. Thanks.
Okay. That was actually high yield right there. So separating systemic and local disease and some system of doing it regularly so you just don't forget.
So the number 2 practice gap was talking about non-operative management of uncomplicated appendicitis, and just emphasizing that this is a possible treatment option now. So, and not only is it possible, but it also has decreased days of hospitalization, decreased days of disability, and equal outcome measures otherwise. So I know standard of care is obviously still the appendectomy, but this was emphasizing that this is a viable treatment option. So our question for the audience is, are you considering non-operative management of acute appendicitis?
So while this is polling, of course, Dr. Holcomb has something to say about this.
Not surprised.
So most people here in the United States know that there are a couple of prospective trials looking at the efficacy of non-operative management versus operative management for non-perforated appendicitis. To me, the important point in this discussion is not whether or not non-operative management is effective for 6 months or a year. It's what's going to happen 10 years down the road or 20 years down the road or 40 years down the road. It's hard to believe that the appendix doesn't scar somewhat due to the inflammation, which may predispose it to developing an obstruction and acute appendicitis later. And whether that's, again, 10 years or 30 years or whatever, that's going to be really important, I think, in trying to determine if non-operative management is really effective. So the point is that these patients, I hope, will be followed for a long time, this cohort of patients in these trials, so that we'll really know, 20 or 30 years later if non-operative management truly is effective. Currently, it appears somewhere between 10 and 20% develop recurrent appendicitis, although somewhere between perhaps 20 and 40% develop or have an operation at some point because they have symptoms that are either similar to appendicitis or their parents are concerned they have appendicitis. So anyway, all that data is just as important, to me at least, whether or not the actual management is effective. It's does the patient get an operation for whatever reason, either soon after the non-operative management or 10 or 20 or 30 years down the road.
I think that's a great point. We just don't know enough yet. Yeah.
The APAC trial, which was an adult study, mostly based in Finland, looked at 5 year outcomes. It randomized adults to either get an appendectomy, which in Finland, apparently they still do open appendectomy. So it was an open appendectomy to a non-operative management. And at 5 years, when they looked back, 41% of the non-operative group underwent an appendectomy. So, and when this was published in JAMA earlier this year, and the editorial accompanying that said they consider this a success, that non-operative management of appendicitis is great. I don't know if any surgeon would look at that and go 41% failure rate is a success.
Steve.
So we would add that in the adult population, there's a PCORI-funded study that is multi-institutional based out of Seattle, but we participated in Los Angeles. And part of the ramp up to that, we had to survey parents to see what they would accept as a potential success for non-operative management.
That's great.
And parents actually came up with, if there was a 50% chance of being successful, they would enroll in the study. So it just, I think it really shows the differences between what the patients view and what we view as surgeons. And in addition, you know, where we are in Los Angeles, lots of patients are coming in, families just asking, we want non-operative management. And so we have to actually address this head on, so.
Yeah, I think my comment to that would be that I think the parents are more focused on the here and now. That is what's happening at that moment in the emergency room. Whereas we, as their caregivers, need to be thinking about what's best for the total life of the patient, whether it's a child or an adult. And that's why I think the long-term follow-up is going to be vitally important for this group of patients.
Right, we have them now in a controlled environment versus when they get it the next time, who knows where they'll be and if it's going to be perforated. I use this as something in my back pocket now. So I don't do it, but I have it there. So if someone's not a good surgical candidate for whatever reason, I don't want it, then I know I have it as an option, but I don't do it. What's interesting, Steve, is that no one has ever asked me for it. So it shows you how it's either an education thing, it's people are hearing stuff. Somehow people have never asked me, but in your facility, people ask all the time. It's very interesting.
And then the poll for this one, most people are not convinced, 72%. And then we had about 20% who were already doing it and 6% who were converted.
I want to I do this sometimes, so I apologize. We're going to jump back because there was a question that I either want Dan or Liz to answer. The question about the Wilms nodes. How many nodes, which sites should you take it from? Contralateral nodes as well. Do either of you want to address that?
So, this is a big controversy, quote, how many nodes? 1 node, 10 nodes, 20 nodes? No one knows. So there are some data to show that 9 nodes, 7 nodes are probably adequate, but plucking nodes from the mesentery or plucking nodes out of the pelvis is not helpful just to get, quote, 9 nodes.
Okay.
And a lot of it depends upon how your pathologist counts nodes, right? If you send them a group of nodes, are they counting that as 1 node, or are they dissecting out every node and looking at every node separately? So I think those are data that we just don't have.
Okay, all right. But you should, Dan says you should take nodes from both sides. Is that okay that I asked a question from the audience?
You're
Did I
totally
step on your
allowed. That's
toes?
okay, Todd.
Okay, all right, okay. All right,
Both sides of the cava and the aorta.
Yeah.
Yes.
both sides of the cava. and
You don't
the-
have to. You don't have to dive into the renal hilum on the other side. Yeah. Yes. Yeah. 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 So I just want to clarify that.
That's
Both
very-
sides of the cava and aorta, not necessarily
The other
dissecting,
kidney.
not
Yeah.
opening up Gerota's fascia on the other side. Yeah.
Great, great discussion. Next,
So we're finally at practice gap number one.
number one.
And this was identified as the most important one because it's the one that impacts most people. Because it's not just our patients, but it's their families and the communities that these medications are going to. And it's about the opioid crisis. And the recommendations we had were to reduce the total amount of opioids prescribed, use non-opioid analgesia, non-pharmacological approaches, and educate on the disposal of unused opioids. This was addressed very thoroughly at APSA annual meeting this year. Many institutions are coming up with protocols either in order sets or family and patient education. They have disposal protocols. And I'm interested in seeing what everyone is doing, including teaching residents, because a lot of people just want to give them opioids.
So what I want to do is get the poll results. David Powell taught me something last year. What our new strategy is that we like repeating topics, even if we did it last year, if it's something that's important enough. We think the best way to get everyone learning something is to keep repeating it over and over again. So Mac Harmon is actually going to be talking about this as well later in more depth. So we're just going to do it again this year. So I was doing this already is interesting. Well, there we go. That's more like I thought. I've absolutely, this is one I completely, after last year's update course, completely flipped my management. I almost never prescribe narcotics now. Okay.
And then the kind of enhanced recovery after surgery protocols that have been around in the adult world for a while and are kind of now making their way into the pediatric world have also been great at reducing opioids, both as in the inpatient setting and at the time of discharge.
Awesome.
Let's see. So the poll over here, I know I was doing it already. They call me the narc police in my residency program. But it looks like 70% were doing it already, 23% have converted, and 8% did not know about this. So I'm really glad we're covering it this year so we can reinforce all these strategies.
Awesome. Great review. Thank you, the three of you. That was fantastic. We'll do this again next year. We'll review the top things from this year. I'm going to move on now.